Good morning, my student. Today we continue discussion about tumors, and we will discussion about tumors of epithelial tissue and tumors of newborn. Also, I repeat, before begin study this topic, you must look book your assembly step 1, where present information about this topic. For example, tumors of epithelial tissue, nomenclature of this tumor. Carcinoma, applied epithelial origin, wherein sarcoma denotes mesenchymal origin. Both terms generally imply malignancy. Benign tumors are usually well differentiated and well demarcated with low mitotic activity, no metastasis, and no necrosis. Malignant tumor or cancer may show poor differentiation, erratic growth, local invasion, metastasis, and increased apoptosis. Terms for non-neoplastic malformations include hematoma, disorderly organization, overgrowth of tissues in their native location. For example, Bates edges, polyps, and corystoma, normal tissue in a foreign location. For example, gastric tissue located in distal ileum in macular diverticules. Also, in this scheme present any nomenclature of epithelial tissue. For example, benign tumor, name adenoma papilloma. Malignant tumor from epithelium, adenocarcinoma, papillary carcinoma. Now, in this present other name from other tissues. Any epidemiology information about tumor from epithelial tissue in this book. For example, skin cancer or basal squamous or melanoma is the most common cancer, not included below. Also, cancer incidence in men, in first place prostate, second lung, third colon, rectum. In women, first place breast, second lung, and third colon and rectum. In children, as a rule, first place leukemia, second CNS, and third neuroblastoma. Lung cancer incidence has decreased in men, but has not changed significantly in women. And cancer mutability present to information in this scheme too. In this picture present any information about pretumor process in epithelial tissue. In left part present normal structure of epithelial tissue, middle part present mild dysplasia, moderate dysplasia where present activation proliferative process, and in right part this picture present severe dysplasia. And sometimes this process can have name as carcinoma in situ. In this histological picture present morphological signs pretumor process. The first step forward neoplasia in cellular transformation. Here there is metaplasia of normal respiratory laryngeal epithelium on the right, to squamous epithelium on the left in response to chronic irritation of smoking. The two forms of cellular transformation, they are potentially reversible, but may be steps towards neoplasm. Metaplasia, the exchange of normal epithelium for another type of epithelium. Metaplasia is reversible when the stimulus for it is taken away. Dysplasia, a disordered growth and maturation of an epithelium, which is still reversible if the factors driving it are eliminated. This histological picture demonstrates two Pretumor processes. This biopsy of the low esophagus in a patient with chronic gastroesophageal reflux disease shows columnar metaplasia, or Barrett's esophagus, and the goblet cells are typical of an intestinal type of epithelium. Squamous epithelium, typical of the normal esophagus, appear at the right. This histological picture continue to demonstrate Pretumor's process. This is the next step toward neoplasia. Here there is a normal cervical squamous epithelium at the left, but dysplastic squamous epithelium at the right. Dysplasia is a disorderly growth of epithelium, but still confined to the epithelium. Dysplasia is still reversible. This histological picture present demonstrates two Pretumor processes. At high magnification, the normal cervical squamous epithelium at the left merges into the dysplastic squamous epithelium at the right, in which the cells are more disorderly. Pretumor's process we can diagnose by cytological research. Here is a cervical pap where in which dysplastic cells are present that have much larger and darker nuclei than the normal squamous cell, with small nuclei and large amounts of cytoplasm. Also, tumors derived from epithelium. Epithelial tumors are divided in two groups, benign and malignant. This scheme demonstrate basic differential feature of benign and malignant growth. Also, we repeat this scheme. Benign growth express atypism, tissue. In malignant growth, tissue and cells. Tight growth, expansive growth by benign tumor and infiltrative growth by malignant tumor. By benign tumor grow as rule slowly, and malignant tumor grow fast. Benign tumor reach big size, malignant tumor rarely reach big size. Benign tumor are subject to ulceration and other secondary change. Malignant tumor often are subject to ulceration and secondary change. Benign tumor do not give metastasis. Malignant tumor give metastasis. Benign tumor recurrence is not characteristic. By benign tumor recur often. Benign tumor mean no influence on patients. Malignant tumor have major influence on general condition of organism. Also, classification of epithelial tumor. Depending on histogenesis, we differentiated tumor of covering epithelium, multi-layer, flat and transition, and glandular epithelium. By the cause and differentiation, epithelial tumor could be non-malignant or benign and malignant. Depending on organ specificity, epithelial tumor are divided into organ-specific tumors and tumors without specific localization. Non-malignant epithelial tumor. Without characteristic localization of covering epithelium have name papilloma. They are found in skin, larynx, urinary bladder, etc. Of glandular epithelium have name adenoma and are found in all glandular organs. Adenoma. Adenoma, this is a epithelial tumor forming glandular pattern as well as the tumors divided from the glands but not necessarily reproducing glandular pattern. Benign epithelium neoplasm producing microscopically or macroscopically visible finger-like or warty projection from the epithelial surface are referred to as papillomas. Adenoma are those which form large cystic masses, as in the ovary, are referred to as cystadenoma. Some tumors produce papillary pattern that protrudes into cystic space and are called papillary cystadenoma. Morphological variants of adenoma. The following morphological variants of adenoma are differentiated: acinosous or alveolar, tubular, trabecular, solid, papillary cystadenoma, villosus adenoma, fibroadenoma. Polyp. When a neoplasm, benign or malignant, production a macroscopically visible projection above a mucosal surface and project, for example, into a gastric or colonic lumen, it is termed as polyp. The term polyp is previously restricted to benign tumors. Malignant polyps are better designated as polypoid cancers. Malignant epithelial tumor are called cancer or carcinoma. The following forms of carcinoma without specific localization are differentiated: epidermoid cancer, developing from multi-layer flat epithelium and is found in corresponding tissues or in mucous tunic where squamous cell metaplasia occurred. Malignant neoplasm of epithelial cell origin are called carcinomas. One within glandular growth pattern macroscopically is termed as adenocarcinoma, and one producing recognizable squamous cell arising in any epithelium of the body would be termed as squamous cell carcinoma. It is further common practice to specify, when possible, the organ of origin, renal cell adenocarcinoma or bronchogenic squamous cell carcinoma, etc. And note infrequently, however, a cancer is composite of undifferentiated cells and must be designated merely as a poorly differentiated or undifferentiated malignant tumor. Carcinomas could be high differentiated. Cancerous keratin presence is characteristic for high differentiated carcinomas, moderate differentiated, and poorly differentiated. This histological picture demonstrates squamous cell carcinoma of skin without keratinization. Epithelial cells with hyperchromic nuclei are seen. They ingrow deep into adjacent tissue. Cellular atrophy is seen in epithelial cells as well as numerous mitoses. This histological picture demonstrates squamous cell carcinoma of skin with keratinization. Epithelial cells with hyperchromic nuclei are thin. They ingrow deep into derma and adjacent tissue. Among cells with hyperchromic nuclei, round-shape formation are seen of homogeneous red color, epithelial cancer, cancerous pearls. The most important human tumors. Here the tumors of lungs, stomach, cervix, uterus, and breast will be discussed. Tumors of the lung. A variety of benign and malignant tumors may rise in the lung, but the vast majority, 90–95%, are bronchogenic carcinomas that in industrial countries are called public enemy number one among all cancers. There are some factors that play an important role in etiology and pathogenesis of this tumor. Tobacco smoking, industry rust, radiation, asbestosis, nickel, etc., air pollution, genetic factors, etc. Role of tobacco smoking. The evidence provided by statistical and clinical observations establishing a positive relationship between tobacco smoking and lung cancer is incontrovertible. Experimental data have also been pursued, but this approach is limited by special differences. Role of industrial hazards. Certain industrial explosions increase the risk of developing lung cancer. All types of radiation may be cancerogenic. The risk of cancer is increased with asbestosis. Among asbestos workers, 1 death in 5 is due to bronchogenic carcinoma, 1 in 10 to pleural or peritoneal mesothelioma, and 1 in 10 to gastrointestinal carcinomas. There is also an increased risk of respiratory cancer among persons who work with nickel, chromators, coal, monster gas, arsenic, beryllium, and iron, and in newspaper workers, African gold miners, and other workers. Role of genetic factors by tumors of the lungs. Occasional family clustering has suggested a genetic predisposition to lung cancer, as has been the variable risk among very heavy smokers. However, attempts at defining markers of genetic susceptibility have proved elusive. Classification tumors of the lung. Numerous histological classifications of bronchogenic carcinoma have been proposed, but they are currently popular ones based on classification of the World Health Organization divides these tumors into 4 major categories: squamous cell carcinoma and adenocarcinoma of approximately acquired frequency 25 to 40% each, small cell carcinoma 20 to 25%, and large cell carcinoma 10 to 15%. Morphology: tumors of the lung. Bronchogenic carcinomas arise most often in and about the hilus of the lung. About 3/4 of the lesions take origin from first, second, and third other bronchi. A small number of primary carcinomas of the lung arise in the periphery of the lung, substance from the alveoli septal cells or terminal bronchioles. These are predominant adenocarcinomas, including those of the bronchoalveolar type, to be discussed separately. Carcinoma of the lung begins as an area of the in situ cytologic ATPZ over an unknown interval of time, as a small area of thickened or peeling up of bronchial mucosa. With progression, this small focus, usually less than 1 centimeter in area, assumes the appearance of an irregular vertex sense that elevator or erodes the liming epithelium. Morphology: tumors of the lung squamous cell carcinoma. This type is most commonly found in men and is closely correlated with smoking history. Squamous metaplasia, epithelial dysplasia, and foci of frank carcinoma in situ are sometimes present in bronchial epithelium adjacent to the tumor mass. This macroscopically picture of squamous cell carcinoma of the lung that is rising centrally in the lung, as most squamous cell carcinoma do. It is obstructing the right main bronchus. The neoplasm is very firm and has a pale white to tan-colored surface. Morphology: tumors of the lung adenocarcinoma. Histological classification of adenocarcinomas include at least two forms. First, the usually bronchial derived adenocarcinoma, and second, some that distinct type termed bronchoalveolar carcinoma, which probably arise from terminal bronchioles or alveolar walls. There may be overlap between these two forms, but the bronchoalveolar carcinoma has sufficiently distinctive growth, microscopic, and epidemiologic features. This picture too demonstrates adenocarcinoma of lung. You can see large white spots demonstrate adenocarcinoma. Morphology: tumors of lung adenocarcinoma. Adenocarcinoma is the most common type of lung cancer in women and non-smokers. The lesions are usually more peripherally located, tend to the smaller and vary histologically from well-differentiated tumors with obvious glandular elements to papillary lesions resembling other papillary carcinomas, to solid masses with only occasionally mucin-producing glands and cells. About 80% contain mucin. Adenocarcinomas grow more slowly than squamous cell carcinoma. Peripheral adenocarcinomas are sometimes associated with areas of scarring. Adenocarcinomas, including bronchoalveolar carcinomas, are less frequently associated with a history of smoking than are squamous or small cell carcinomas. This picture too demonstrates macroscopically signs of cancer of lung adenocarcinoma, white color. As a rule, this is bronchoalveolar adenocarcinoma, other name central adenocarcinoma. Small cell carcinoma, variant morphology: tumors of lung adenocarcinoma. This highly malignant tumor has a distinctive cell type. The epithelial cells are generally small, have little cytoplasm, and round or oval, and occasionally lymphocytic-like. Also, they are about twice the size of a lymphocyte. This is a classic oat cell. Other small cell carcinomas have spindle-shaped or polygonal cells and may thus classified as spindle or polygonal small cell carcinoma. The cells grow in clusters that exhibit neither glandular nor squamous organization. Carcinoma in situ. Carcinoma which does not penetrate through basal membrane and does not invade tissue depths is marked out separately. These histological signs adenocarcinoma in situ. When the anterior epithelium is dysplastic and normal epithelium are left. Then the process is beyond dysplasia and is now neoplasia. If the basement membrane is still intact, as shown here, then the process is called carcinoma in situ because the carcinoma is still confined to epithelium. Gastric tumors. Gastric polyps. The use of the term polyp in the gastrointestinal tract, however, is generally restricted to mass lesions arising in the mucosa. Gastric polyps are uncommon and are found in about 0.4% of adult autopsy and 3 to 5% of Japanese adults. Although gastric polyps are usually found indecently, dyspepsia or anemia resulting from blood loss may promote the search for gastrointestinal lesion. Gastric tumors. The adenoma of the stomach is a true neoplasm, representing 5 to 10% of the polypoid lesions in the stomach. By definition, an adenoma contains proliferative dysplastic epithelium and thereby has malignant potential. Adenomatous polyps are much more common in the colon. Gastric adenomas may be associated without stalk or predicted stalked. The most common location is the distal portion of the stomach, particularly the atrium. These lesions are usually single and may grow up to 3 to 4 cm in size before detection. In contrast to the colon, adenomatous change may carpet a large region of flat gastric mucosa without forming a mass lesion. Among the malignant tumors that occur in the stomach, carcinoma is overwhelmingly the most important and the most common, 90 to 95%. Next in order of frequency are lymphomas, 4%, carcinoids, 3%, and malignant spindle cell tumors, 2%. Morphology is tumor. The location of gastric carcinomas within the stomach is as follows: pylorus and antrum, 50 to 60%, cardia, 25%, and the remainder in the body and fundus. The lesser curvature is involved in about 40% and the greater curvature in 22%. This is for which location is the lesion curvature of the antropyloric region. Although less frequent, an ulcerative lesion on the greater curvature is more likely to be malignant. Gastric carcinoma is classified based on depth of invasion, macroscopic growth pattern, and that histologic subtype. The morphologic features having the greatest impact or clinical outcome is the depth of invasion. Any gastric carcinoma is deemed as a lesion confined to the mucosa and submucosa, regardless of the presence or absence of perigastric lymph node metastasis. And thus gastric carcinoma is a neoplasm that has extended below the submucosa into the muscular wall and has perhaps spread more widely. All cancer presumably begin as early lesions, which present the development of advanced lesions. The three macroscopic growth patterns of gastric carcinoma, which may be evidenced at both the early and advanced stage, are: first, exophytic with protrusion of a tumor's mass into the lumen; second, flat or depressed, in which no tumor mass is visible absorption; and third, excavated, when a shallow or deeply erosive crater is present. Adenocarcinoma. Carcinoma from glandular epithelium is called glandular neoplasm or adenocarcinoma. It occurs in organ with corresponding epithelium and also could be of three stages of differentiation: high differentiated, moderate differentiated, and poorly differentiated. Breast tumors. A great variety of tumors may occur in the family breast. Only the more common tumors related to the breast will be discussed. The most common benign tumor of the family breast is fibroadenoma, a new growth composed of both fibrinous and glandular tissue. Occurring at any age within the reproductive period of life, it is somewhat more common by the age of 30. Multiply small arrays closely resembling fibroadenoma are sometimes found in cases of cystic disease termed fibroadenomatosis. Morphology of breast tumors. The fibroadenoma grows as a spherical nodule that is usually shapely circumscribed and freely movable from surrounding breast tissue. They vary in size from 1 cm to giant forms, 10 to 15 cm in diameter. The histologic pattern is essentially one of the delicate cellular fibroblastic stroma resembling intralobular stroma, enclosing glandular and cystic space lining by epithelium. Intact, round to oval gland space may be present, lined by single or multiple layer of cells. In other areas, the connective tissue stroma appears to have undergone more active proliferation with compression of the gland spaces. Carcinoma of breast. Breast cancer causes some 20% of cancer deaths among females and has been called the foremost cancer in women. The incidence has been increasing steadily over the past 80 years, so that currently 1 of every 9 women in the USA will develop cancer in the lifetime. Continue. Classification and distribution carcinoma of breast. Among breast carcinomas small enough for their general areas of origin to be identified, approximately 50% arise in the upper quadrant, 10% in each of remaining quadrants, and about 20% in the central or suboreal region. The World Health Organization classification of this tumor is as follows. A. Non-invasive or intraductal carcinoma with Paget disease, lobar carcinoma in situ. B. Invasive or infiltrative, invasive ductal carcinoma with Paget disease, invasive lobar carcinoma, tubal carcinoma, adenoid cystic carcinoma, apocrine carcinoma, invasive papillary carcinoma. Only the more common types will be discussed. Non-invasive or in situ carcinoma or intraductal carcinoma is defined as a malignant papilla of cells that lack the capacity to invade through the basement membrane and therefore are incapable of distant metastasis. But these cells can spread through a ductal system and produce extensive lesions involved in anterior sector of a breast. Movement of these cells of the main duct and into the nipple skin results in the clinical appearance of Paget disease of the nipple. Paget disease is a form of ductal carcinoma that arises in the main excretory ducts of breast and extend intraepithelially to involve the skin of the nipple and areola. The skin lesions are invisibly associated with an underlying ductal carcinoma in situ, or less common by invasive ductal carcinoma arising deeper within the breast. The histologic hallmark of this entity is the involvement of the epidermis by malignant cells. That's why the skin of the nipple and areola is frequently fissured, ulcerated, and oozing with surrounding inflammatory hyperemia and edema. The prognosis is dependent on the underlying carcinoma. There are some types of invasive infiltrating carcinoma of the breast: invasive ductal carcinoma, medullary carcinoma, colloid or mucinous carcinoma, invasive lobar carcinoma. This picture demonstrates tumor of intestine, large intestine carcinoma. Wall of large intestine deformed in favor of bulk, like thickening with considerably narrow clearance of intestine bulk of mucous tunic. This macroscopically signs gastric carcinoma on serosa. Multiply nodes of white color and various size are seen on gastric serous tunic. This pancreas cancer macroscopically organ is represented with white color nodules which are interronding. This macroscopically signs adenocarcinoma of pancreas is very extensive, sparing only the uncinate process at the low left center. Chronic biliary tract obstruction from this mass, producing icterus marked by the green color of the liver after formalin fixation. A tumor invaded into the hilum of liver, and small metastases of liver are also present. This is histological signs. At high magnification, this adenocarcinoma of the gallbladder is composed of columnar cells forming glandular and papillary structure. The prognosis with adenocarcinoma of the gallbladder is usually poor because they have often invaded and metastases by the time they are discovered. In this picture, we demonstrate the medium power microscopic appearance of the adenocarcinoma of the pancreas. Just to the left of centrum can be seen perineural invasion by the neoplasm, which is composed of very irregular gland. This histological picture at high magnification microscopic appearance of adenocarcinoma of the pancreas seen. At the left can be seen normal pancreatic acini, but the neoplasm is composed of small irregular gland. Polydifferentiated adenocarcinoma. Peculiar for polydifferentiated adenocarcinoma is sclerosed carcinoma, containing big quantity of fibrous stroma squeezing tumor parenchyma. Undifferentiated forms of epithelial malignant growth are represented with small cell carcinoma, carcinoma signaling ring cell carcinoma, and medullocarcinoma. This picture demonstrates histological signs at high magnification. Adenocarcinoma of pancreas has very poorly differentiated gland and extensive desmoplasia, the production of collagenous stroma. These histological signs tumors in pancreas. An islet cell tumor of the pancreas is seen at medium power. Note the similarity of the cells forming the neoplasm with the cells in the normal islet of the pancreas at the right. Malignant growth, specific epithelial growth, including chorion carcinoma and trophoblastic tumor, clear cell carcinoma of kidney, etc. This macroscopically signs a renal cell carcinoma, or as a name, hypernephroma. Tumor node is in kidney upper pole. It is stippled on section, yellowish color. Portions alternate with portions of hemorrhage. Next part of our lecture features of childhood neoplasia, dysontogenic tumors, teratomas, and teratoblastomas. Tumors in infants. Peculiarities. They often develop from embryonal tissues as a result of the development and formation disorder. These are dysembryoma or teratoid tumors, teratomas. Benign tumors, angiomas, aneurysms, occur more often than malignant. Certain benign tumors are inclined to infiltrative growth, angiomas. Sarcomas, lymphosarcomas, osteosarcomas are found more often than cancer, or with occur mostly in internal organs, endocrine glands. Malignant tumors, embryonal carcinosarcomas, hepatoma, in infants keep expansive growth for quite a long time. Don't metastasis for long, and even are able to reversible to transfer into benign tumor, neuroblastoma into ganglioneuroma. Malignant tumors in infants most often are found in children of 3-5 years, which confirms significance of antenatal cancerogenic influences. Classification: tumors in infant. The first type are dysembryomous, teratoid tumors or teratomas. They could be gystioid, organoid, organismoid, and embryonal, which could be homologous teratomas and heterologous teratoblastomas. Histioid teratomas are also called gamartomas, angiomas, nevi, embryonal tumors of internal organs, or hamartoblastomas. Second type, tumors in infant. These tumors which embryonal Campbell tissues in nervous tissue, sympathetic ganglia, adrenal glands, medulloblastomas, retinoblastomas, neuroblastomas. They also could be referred to as gamartoblastomas. Third type, tumors in infant, are tumors developing like adult tumors. These are tumors of mesenchymal origin, gammablastoma, osteogenic, and tumors of soft tissues. Dysembryomos, gamartomas and gamartoblastomas of vascular origin, among which capillary and cavernous hemangiomas on skin in the form of red bluish node are found most often, as well as in liver and other organs. Capillary hemangiomas have ability for infiltrative growth, so they can recur after oncotomy. Angiosarcomas and lymphangiomas are found rarely. They can reach big size on the neck with endothelium and capillaries proliferation and infiltrative growth. Two dysembryomos present gamartomas and gamartoblastomas of cross-tipped muscles, rhabdomyomas, which are found in heart extremities muscles as 10-15 cm node of gray-brown color. Rhabdomyoblastoma or embryonal rhabdomyosarcoma, malignant tumor which is found in small pelvis organs. Gamartomas of internal organs. Wilms tumor or embryonal carcinoma, carcinosarcoma. Wilms tumor or adenosarcoma grow expansively in capsule for long, can reach giant size, reddish white color with hemorrhagia. Histologically, in tumor among kidney tissue structure, elements of mesenchymal origin are found. Hepatoblastoma or embryonal hepatoma. Malignant tumor of HEPA. On section, it looks like numerous white yellowish nodes of solid fields of embryonal hepatic tissue and structures of mesenchymal origin. Metastasis complicated with internal hemorrhages. This macroscopically picture of embryonal carcinosarcoma of kidney. Grow expansively in capsule for long, can reach giant size, reddish white color with hemorrhagia. In down part present normal structure of kidney. Teratomas and teratoblastomas. Organismoid and organoid teratomas tumors derived from 3 germ layers are found in testes, ovaries, mediastinal, extraperitoneal base of brain. In girls' ovaries, malignant teratoblastomas develop more often, and benign teratomas in testes, as through teratomas grow as polyps, are in benign course. Intracranial teratomas more often are of malignant course. They often are hormonally active. Tumors of cambial embryonal tissue can be medulloblastoma, is malignant tumor in tentorium. Retinoblastoma is malignant tumor from embryonal poorly differentiated cells of retina. Neuroblastoma is malignant tumor in sympathetic ganglia, adrenal medulla, fast metastasis, disc catecholamines. Tumors developing like adult tumors. These tumors are of nervous system, astrocytomas, gametopoietic system, leukemosis, malignant lymphomas, bones tumors, osteomas, chondromas, osteosarcomas, Ewing sarcomas. This macroscopically picture demonstrates malignant lymphoma of mediastinum. This tumor pressure on heart and develop heart failure. Also, before finish our lecture, you must answer on control test of the lecture. First question: pretumor process, metaplasia, dysplasia. A. Metaplasia. B. Dysplasia. Second question: benign tumors derived from epithelium. A. Papilloma. B. Cancer. Third question: benign tumors derived from epithelium. A. Papilloma. B. Polyp. Fourth question: this tumor is infiltratively increasing. A. Papilloma. B. Cancer. 5 question: teratoma derived from A. 3 layers, B. epithelium. Thank you for the lecture, for your listen.